Bismillahirrahmanirrahim. Today, before we commence with the exams, this is a revision lecture in which we are going to go over all the syllabus that we have studied up till now. We're going to start with the first chapter, and I will go briefly over it. I will stress the important points, and I will go over it quickly. And if there are any questions, we can discuss it in our online class. Now, pathology, as we know, this is where we study the diseased body. The thing is, what we are looking for, why it happened, and how it happened. So, what we are doing, we are looking for disease. Basically, disease, this is something which causes a structural change or a functional change within a living tissue. Now, there are two types of pathologies, general and systemic. General deals with the basic reaction of the cells in the body to abnormal stimuli. Systemic, this is more specific, where we deal with diseased systems like the respiratory system or the GIT system, nervous system, etc. Now, if we look at the disease, there are four aspects to it. There's the etiology. Etiology means the cause. Cause can be intrinsic or genetic, which comes from within the body, or it can be acquired, which you get from outside the body, like infections, any nutritional pathologies, any chemical injuries, any physical pathologies. Pathogenesis, this is the sequence of events which you see in a body, which start from the point when an etiological agent is introduced into the body till its final outcome. The final outcome can be anything. It can be recovery, it can be disability, it can be a paralysis, or it can even be death. Morphological changes, these are the structural changes that you see within the cells or the tissues which are characteristic of a particular disease. Now, functional derangements and clinical manifestations, obviously, when there is going to be some sort of a morphological change which is specific to a certain disease, you are going to see specific signs and symptoms which are related to that disease. And these will lead you towards a diagnosis and prognosis of that disease. Now, let's look at the adaptive processes. These are four: hypertrophy, hyperplasia, atrophy, and metaplasia. Now, if we look at hypertrophy, hypertrophy is where there is an increase in the size of the cell. In this, the number of cells, they do not increase. In this, the size of the cell or the size of the organ increases. There are no new cells formed in this adaptive response. What happens is the cellular component that increases, due to which the cell size increases. And please keep it in mind, this is not a swelling, this is an increase in the size of the cell, which collectively leads to increase in the size of the organ. Causes, there can be increased functional demand, due to which the an organ, it increases in size. There might be some hormonal stimulation, or there might be some growth factors involved in this. Where if you look at physiological hypertrophy, uterus is a classical example in which there is hormonal stimulation, due to which the size of the cells, they increase. Bodybuilders, again, this is another classical example where hypertrophy in physiological condition is seen. In this, due to the increased workload, due to the excessive weights that they are pumping, due to that, the size of the skeletal muscles, they increase in size due to the increased workload. Pathologically, if you look, I think I would say the most common example that you're going to see is cardiac overload, where the heart hypertrophies. That is due to increased workload onto the heart. That can be due to different reasons. It can be hypertension, it can be atherosclerosis, it can be some other cardiomyopathies, anything which leads to uh, an increase in the workload of the cardiac muscle, that leads to an increase in the size of the cardiac muscle. Initially, yes, this might be beneficial, but in the long run, this can have very disastrous effects. Now, why is it that hypertrophy, it stops after some time. Why doesn't it keep on going? Because if the workload is increasing, why doesn't the hypertrophy also keep on increasing with it? The factors that come into play are: first, the blood supply that is finite. There is a limit to which new blood vessels can be formed by a body. The second thing is the capacity of the mitochondria to produce ATP. Again, they can increase their functionality, but again, there is an upper limit beyond which they cannot go. The third thing is that the increase in size is due to the increase in the cellular component and the raw material which is making that cellular component. Again, the supply of that raw material is again finite, it is not indefinite. So when these things they start saturating, when they start finishing, the process of hypertrophy, it starts decreasing, it starts to stop. Now let's look at hyperplasia. Hyperplasia, and this, the number of cells in an organ, they increase in number. It's not the size, in this the number of cells, and this is only possible in those organisms, in those organs and tissues which have the capability of mitosis. Unless and until a cell has the capability of mitotic division, it cannot undergo hyperplasia. So classical examples that you might see physiologically, if you look, there can be hormonal stimulation or there can be compensatory stimulation. Again, in hormonal stimulation, uterus is a very, very classical example in which there is not only hypertrophy, you also see hyperplasia. So in uterus, not only the size of the cells is increasing, the number of the cells is also increasing. Now, compensatory, this is seen in organs like liver and in organs like kidney. If a portion of the liver, it is cut off or it is damaged, what you see is if the rest of the stroma is preserved, the rest of the liver tissue is intact, what it does, it can grow back to its full size. Now, this capability only comes when there is some damage to the liver. So these cells, they have compensatory hyperplastic tendencies, that if a certain circumstance arises, yes, the tissue can definitely proliferate, it can regrow to its original size. Now the mechanisms, they say there are certain growth factors which come into play, and when once the proliferation has been completed, when an organ has reached its destined size or its destined shape, what happens then? Then the inhibitory factors, they get activated and then they stop that proliferative process. Now the atrophy, in atrophy there is a decrease in the cell size. The size of the cell decreases due to a decrease in the cellular component. Please remember, atrophic cells are not dead cells, they are just cells whose size has decreased, but they are living cells. And ultimately, yes, with time, like any other cell, when the time comes, an atrophic cell is going to die, but an atrophic cell by itself is not a dead cell. Physiologically, you can see it in early development in pathologies. Again, your atrophy can be seen locally or in a generalized manner. Now, if you look at the causes, again, atrophy, decreased workload, thing we call disuse atrophy. Classical example, when there's a fracture, you have a cast, and when you take it off after 3 months or after 6 weeks or after a long duration of time, what you see, your limb, it has shrunk in size. Why? Because due to the fixation, the limb was not able to move. It was not being put to its full usage. So the cells in that area, they shrunk in size because at that time they were not functioning. So this is known as disuse atrophy. Then there is loss of innervation, when the nerve to a certain cell or a certain tissue that gets damaged. So then the impulses, they cannot reach that tissue, because the impulses are not there to excite the tissue. Again, due to that this problem, that tissue can undergo atrophy. Classical example is wrist drop, which we see if the injection is given at the wrong place. Now, in cases of ischemia, again, If the blood supply to a certain tissue is becomes less, it becomes decreased, again that tissue, those cells can atrophy due to a decrease in their blood supply. Again, if the nutrition is not a well balanced diet, if you are missing important ingredients from your nutrition, again the body, yes, you will see atrophy in specific or the whole of the organs of the body. Then loss of endocrine stimulation. Again, if there are certain hormones, there are things which are essential in our body for the normal functionality. Again, if there is a loss or some pathology in these things, you will see atrophy of the related tissues. Then aging, senile atrophy. This is as a person ages with the senile changes which occur, the normal physiological changes that you see as a person gets older, and as all the systems, they are slowing down, their functionality is decreasing, again you will see a lot of cells, they will be undergoing atrophy. Then pressure from above or from the sides, like if there is a tumor somewhere, again if it's going to grow, then it's going to pressurize the surrounding tissues, and if they are pressurized, what will happen due to the pressure, the the cells will become compressed. Even the blood vessels which are running between these cells, they will also get compressed. So there is not only pressure over these cells, there is also going to be ischemia. So again, these cells can go atrophy, they can undergo atrophy. Mechanism is not exactly known, but again the thing that comes into mind is that there is a decrease in the protein synthesis, there is degradation of the cellular proteins, and in some cases what they have seen, that autophagy may also be present in these scenarios. Metaplasia is something in which there is a reversible, remember, reversible change of one adult cell type into another adult cell type, and this is due to there is some sort of a trauma, there is some sort of a condition which the original cell type cannot tolerate, so that sensitive original cell type is replaced by a more stronger cell type which can withstand that stimulus. But the problem is that when this replacement takes place, the second type of cells, they are they are not functional in the capacity as the first cells were, and metaplasia can definitely lead towards malignancy in the later stages. Classical example is the epithelia of the smokers due to the nicotine and other chemicals which are inhaled. The normal columnar epithelium of the respiratory tract, it cannot tolerate those strong chemicals, that strong nicotine, because it injures these cells. So what happens with time, these columnar cells, they are replaced by squamous cells. Now, squamous cells are stronger cells, they are more robust cells, they can withstand these toxic chemicals. But the problem is the squamous cells cannot perform the function which the columnar cells did. So, if this condition, if the stimulus is not removed, these squamous cells, they will ultimately, this change will change from reversible to irreversible side, and once it becomes irreversible, then that becomes a very strong foundation for malignancy. Now, causes of cell injury, if you look at cell injury, it has two stages. There's the reversible cell injury, and then there's the irreversible cell injury. In the reversible cell injury, the stimulus is, if the stimulus is removed, then the cell will become normal. But if the stimulus persists, that reversible stage is going to go into irreversible stage. Now, in the reversible stage, what happens is there is a decrease in the oxidative phosphorylation. This in turn leads to a decrease in the ATP production. Gradually, ATP starts depleting, it starts finishing. Now, when that happens, these receptors, the channels which are guarding the movement of different chemicals from chemicals which are going to enter or leave the cell. they become disrupted. So when these channels they do not get the required energy to function properly, what happens? The channel doors, they open up, and sodium and water, it starts coming into the cell. Now as there is no check and balance, sodium and water starts coming into the cell and the cell starts to swell up. This is known as hydropic change. Hydro, water, hydropic change, swelling. Now, if the stimulus is not removed at this stage, then the cell is going to go into the irreversible stage. Irreversible stage means that the cell is ultimately going to die. If the stimulus is removed at this stage, the cell will revert back to its normal position. Now, in the irreversible stage, the damage is there. The stimulus is persistently damaging the cell. Now, what it is doing, it is damaging the mitochondria, it is damaging the cell membrane, it is affecting the permeability of the cell membrane. Once the permeability of the cell membrane that becomes injured, the integrity is lost, then the cell is doomed, the cell is going to die. Now what can be the causes? There can be, if the oxygen supply is not there, there can be physical agents like trauma, extreme temperatures, radiation, shock. Then there are a lot of chemicals, the list is endless, lot of chemical agents, lot of drugs which can cause a cellular injury. Then infectious diseases caused by viruses, bacteria, protozoas, your parasites. I mean, the list is endless. Then immunological reactions, autoimmune reactions, anaphylactic reactions. I mean, there are a whole list of things which can cause injury to a cell, and whatever the etiology might be, the reaction the cell is going to show, it's going to be exactly the same. First there's going to be the reversible stage, then there's going to be the irreversible stage. Now if you look, then there are the genetic side like Down syndrome, sickle cell anemia, then nutritional imbalances like anorexia nervosa, marasmus. I mean, there the list is endless. Anything which can cause damage to a cell, that leads to these changes which we have just discussed. Now let's look at necrosis. Necrosis, very very important, a very common feature, it's the basis of pathology. Now in necrosis, it's a spectrum of morphological changes that follow cell death in a living tissue. Necrosis cannot happen in a dead tissue. So if there is cell death within a living tissue, that is known as necrosis. And the thing is, why does it happen? What effects that you are going to see? We'll just go over them. Uh, we'll reiterate them. Now, the morphological appearances that you are going to see in these things are: first thing, there is going to be denaturization of the intracellular proteins, and there is going to be enzymatic, because once these cells are destroyed, the lysosomal enzymes, they are going to be released and they will start eating up the those tissues and those cells which have become injured. Also the WBCs, which will be attracted towards the injury site, they also release their lysosomal enzymes and they too will start phagocytosing and degrading. So at this stage there is autophagy and there is heterophagy. Both things are both things start simultaneously. Then the nuclear changes in necrosis, you are going to see three patterns. Pycnosis, in this the chromatin clump together and they shrink, and you will see increased basophilia. They will appear blue. Then karyohexis, in this there is fragmentation, the chromatin, they just break away into small pieces. And the third pattern is karyolysis, where the chromatin material, it just fades away, it just disappears. So this all this necrotic debris, this is phagocytosed, and the particles which are not phagocytosed, they attract calcium salts and they bind with these calcium salts and form calcifications. This is known as dystrophic calcification. Now the mechanism of necrosis: hypoxia, Hypoxia can be caused by ischemia, it can be caused by anemia, it can be caused by different poisonings like carbon monoxide poisoning. It can be due to some pulmonary disease due to which proper oxygenation of blood is not taking place within the lungs. So, this injury is again going to cause the early reversible changes, or if the stimulus is not corrected, it is not removed, then it will proceed into the irreversible stages. In the early we have already seen, but here we will look at these stages at a little more detail. First, the sodium potassium pump, it is going to fail because what we just discussed earlier, ATP is not being formed to its full strength, it is depleting, it is decreasing. So when the energy is not there, your sodium potassium pump is the first to go, and when this pump becomes non-functional, sodium and water is going to come into the cell, it is going to come intracellularly, and the cell is going to swell up. This is known as hydropic change. Apart from that, the ribosomes, and they will start disaggregating. That means they will start breaking up, due to which protein won't be synthesized. If the stimulus is not removed at this stage, then it will proceed into the irreversible stage, where there is going to be influx of calcium. When the calcium comes, it has a positive charge. What it will do, it will lower the pH, it will make it acidic. Now in acidic medium, the enzymes, they become activated, and then these enzymes are going to damage the cell. This damage is going to involve not only the cell but also its cell membrane. Now when this happens, this is irreversible change, and the damage is going to be not only to the cell wall but all the cellular components, and ultimately this is going to end into death. Then another is free radicals. Now in this, free radicals, these are molecules which have got a single unpaired electron in its outermost orbit, and the problem is these free radicals, what they do is they destroy the nuclear membrane and the outer membrane of a cell. When they do this, again the membranous integrity of a cell is destroyed, due to which irreversible changes in the cell. You can see all those changes, and that results in cell death. Now usually free radicals are normally also produced in our body, but are antioxidants. Our body also produces them. Antioxidants are also present in our diet, so we can neutralize this. But like when we take drugs, chemicals, or oxygen toxicity, all these conditions, yes, there are sometimes these free radicals increase so much in number. Their production is so high that the body is not able to neutralize them. Then they start causing tissue damage, which results in cell death. Then your components which damage your cell membrane, like extreme temperature, toxins, virus, hypoxia, and increased intracellular calcium levels. Again, if calcium level is increased due to any reason, calcium is a positive ion which decreases the pH. Whenever the pH is going to be decreased, the lysosomal enzymes are going to be released. When they are going to be released, your cell membrane integrity is going to be destroyed, due to which there is going to be cell death. Type of necrosis, if you look at it, first there is coagulative necrosis. This is basically due to if there is sudden interruption to the blood supply of a cell or an organ. But in this, generally the tissue architecture is preserved. So basically the injury is due to a sudden blockage in the blood supply of a specific tissue. Now the next is liquefactive necrosis. In this liquefactive necrosis is basically seen in the brain, and in this the normal architecture is not preserved. In this, the tissue, it forms a viscous, thick fluid like material, and this type of inflammation is specifically seen in the brain. I mean, brain does not have coagulative necrosis. Whenever necrosis is going to occur in the brain, it is always going to be of the liquefactive type, and liquefactive type is where the cell destruction leaves back a debris which is in the form of a thick, viscous fluidy material. And in liquefactive necrosis, the normal architecture is not preserved. You cannot recognize the normal shape, size, and you cannot identify what sort of a cell that was. Fat necrosis, this is caused by trauma to tissues which have a high fat content, or due to pancreatic enzymes. Now, fat necrosis then technically can be traumatic or enzymatic. If there is trauma to the fat cells, then that is going to be of the traumatic variety. If it is due to pancreatic enzymes in acute hemorrhagic pancreatitis, where the enzymes they diffuse out of the inflamed pancreatic tissue and they start eating the pancreas. If it is of that type, then it is known as the enzymatic type. So fat necrosis can be traumatic type or enzymatic type, but in both cases, the tissue content should have a high fat levels. Caseous necrosis, this is specifically seen in tuberculosis. Caseous means cheese-like, so this has appearance of a cheese, like a cheesy white gross appearance, and this is specifically we use it where tuberculous necrosis is seen. And this caseous necrosis, it is usually surrounded by an inflammatory border, and this is known as a granulomatous reaction. Gangrenes, we have seen these. You have known the dry gangrene. Usually this is due to arterial blockage, whereas the wet gangrene, that is due to venous blockage. But the thing is, dry gangrene is not basically pure gangrene, because for the classical gangrene definition, there has to be necrosis, there has to be putrefaction, and there has to be bacterial infection. Whereas in dry gangrene, uh, neither putrefaction is there, neither bacterial infection is there. So, still, as this name has been used for so many years, and it's still being used. This thing is still known as dry gangrene, but technically, if you look at it, basically this is mummification, where the pure gangrene, if we really discuss it, it is the wet gangrene. But whatever the case, you will see that these gangrenes, they show a black color, which is due to iron sulfide. And in the case of wet gangrene, the inflammation, the putrefaction, the bacterial infection, the inflammatory exudate which is formed, that gives it the wetness which is seen. Apart from that, the proteins that are digested by the bacteria, again, those when those proteins are digested and eaten and enzymatically degraded, they give that foul smell. Because as bacteria are not essentially involved in dry gangrene, usually dry gangrenes do not give a smell, they do not have a bad smell. But the wet gangrene, it definitely has a very bad smell. And gas gangrene is if there is a penetrating injury and anaerobic microorganisms are involved in a wet gangrene. That wet gangrene then turns into a gas gangrene, because anaerobic microorganisms, when they cause reactions, they produce gas apart from iron sulfide, putrefying debris, and the other inflammatory exudate. Apoptosis, this is programmed cell death. It is enzymatically programmed by the body, cells or tissues which no longer the body needs, it just gets rid of them through this process. Now, this is a very controlled process. Nowhere in this process the cellular membrane is broken. Apoptotic bodies are formed which are phagocytosed by the macrophages and totally degraded. No inflammatory reaction is there, because the cell membrane always remains intact. So this is a process through which body gets rid of any unwanted cell, and it is totally programmed by the body. It is not something random. So apoptosis can be, usually in most cases it is physiological, but sometimes apoptosis can coexist with necrosis, but in those scenarios, this apoptosis is going to be pathological. If you look at the morphology, first there is cell shrinkage, then chromatin condense, then cytoplasmic blebs and apoptotic bodies are formed, and these are taken up by the macrophages, and they are degraded by the lysosomal enzymes which are present in these uh, macrophages, which degrade these apoptotic bodies. Lysosomal, primary lysosome, this is a membrane-bound organelle which contains the enzymes. Secondary lysosome, when the primary lysosome fuses with the vacuole which has to be digested. Heterophagy, in which the digested material is ingested from outside the cell and it is taken in by the cell and then the lysosomal enzymes digested. Autophagy, when the material is present within the cell and and forms an autophagic vacuole and then the lysosomal enzyme degrades that vacuole. Uh, Now, if you look at the smooth endoplasmic reticulum, again, it is seen, it shows adaptive tendencies. If these cells are exposed to certain chemicals, these reticuli they hypertrophy in an adaptive response. Like classical examples, like we use drugs like barbiturates. Why do we develop tolerance to these? Because as we keep on taking these drugs for a prolonged period of time, these endoplasmic reticulum they adapt to these drugs and they increase in volume, they hypertrophy, they increase in size. When they increase in size, they more effectively they are able to metabolize these chemicals. Then the effect, the doses of that certain drugs that becomes inefficient when tolerance is developed. So again, an example of adaptive process. Mitochondrial alterations, again, hypertrophy, atrophy, all of these things you will see in your mitochondria. Cytoskeletal abnormalities, again, uh, the structure which cytoskeletal forms, they are the microtubules, then actin filaments, myosin filaments, then the intermediate filaments. Intermediate are keratin filaments seen in the epithelial cells, neurofilaments in the neurons, vimentin in filaments in the connective tissue, then glial filaments in the central nervous system, then the contractile proteins. Any abnormality in these are going to lead to abnormalities to which these cells are related to. If you look at intracellular accumulations, there can be lipid accumulations. Classical example is where triglycerides they are accumulated in the liver, and these are seen in protein malnourishments, in diabetes, in obesities, in anoxias, in alcohol abuse. I mean, there are a lot of conditions in which what you will see, if triglyceride content is increased, it gets deposited in the liver. So you get a fatty liver, you see fatty changes which are very easily evident in the liver. Now, lipids, fat can also accumulate in other places like atherosclerosis, that is in the smooth muscles or in the macrophages, xanthomas. These are these accumulate in macrophages which are present in the skin. Then inflammation and necrosis, again, foamy macrophages are found at sites where inflammation and necrosis occurs. And cholesterolosis, these are foamy macrophages which are seen in the gallbladder wall. Proteins, again, they get accumulated, but their accumulation is not that common as compared to the fats. Common examples that you see of protein are in yes, in liver, alcoholic liver. You can see them in kidneys, like in nephrotic syndrome. They accumulate as eosinophilic droplets, vacuoles, or aggregates within the cell. Glycogen, again, something which is usually seen in poorly controlled diabetes or some glycogen storage diseases. And again, not that common, because usually fat accumulation is the most common pathology yet that you are going to encounter. Pigments can be endogenous or exogenous. Exogenous come from outside the body, like carbon. We inhale carbon. Again, we don't have enzymes to digest carbon, so our macrophages, they just pick up this carbon and they phagocytose it. But as they cannot digest it, they take it to the lymph nodes, and again, the lymph nodes, they too cannot digest it. So what you will see is that these carbon-filled macrophages will be seen in the lymph nodes. They will be seen in the tissues, and this condition is known as anthracosis. And when these macrophages, these carbon-laden macrophages, they start causing cellular damage, this condition becomes Kohlberger's pneumoconiosis. Now, endogenous lipofuscin, this is the wear and tear or aging pigment. It is an insoluble brownish yellow pigment, and it accumulates in the heart, liver, brain, and usually it is seen as a person ages or some atrophy starts. And it just indicates that that tissue has gone through some injurious some injurious experience in the past. It just shows the wear and tear of that tissue, what happened, how has it passed its time through the different as the years have gone by. Melanin, this is the brown black pigment which gives color to our skin. This is produced by melanocytes, and this is when tyrosine is converted to dopa in the presence of tyrosinase enzyme. And this enzyme, this pigment is very important as it protects us from the ultraviolet rays. Hemosiderin, this is a derivative of hemoglobin, golden yellow in color, and when hemoglobin is degraded, this is the final product which accumulates in our body. It can accumulate locally or it can accumulate systemically, and its accumulation usually tells us the load of iron in our body. If there is if you find there is overload of iron in your body, but there is no damage or no dysfunction seen in any tissue or organ of the body, then we call this condition as hemosiderosis. But if we find there is overload of iron, hemosiderin is deposited in many organs, and it is causing dysfunction to these organs. It is damaging those organs. Then this condition is known as hemochromatosis. Now, dystrophic calcification and metastatic calcifications, these are abnormal depositions of calcium salts within our tissues. In dystrophic calcification, there is deposition of calcium in dead or dying tissue. And in this, calcium levels and calcium metabolism is absolutely normal. In metastatic calcifications, sorry, uh, in metastatic calcification, the calcium metabolism is deranged. Normal calcium levels are high. You will find hypercalcemia. Now let's look at, I will go through inflammation quickly. Inflammation, basically this is a protective response in which our host cells are involved, our blood vessels are involved, our proteins and other mediators are involved. And what do they do? What happens is when there is some injury to a cell and necrotic material and destruction is being done, inflammation is there to control that injurious agent, to get rid of that necrotic material and to start healing and repair. Now, if you look at now, inflammation can be of two types: acute and chronic. Acute is the reaction of vascularized living tissue to local injury, and this is okay, it's acute. It is immediate. It is the earliest response that you are going to see, and it is going to be short-lived, lasting for a few minutes to a few hours, or even for a few days. You are going to find exudate here, and you are going to find the dominant cell which is going to be neutrophil. The cardinal signs of inflammation: redness, this is due to dilatation of the blood vessels. You will find heat due to increased blood flow, swelling due to increased vascular permeability, pain due to stretching and destruction of the tissues, and loss of function due to pain and swelling, which will not be able, due to which a person is not able to carry out the normal movements. Now, in inflammation, there is early vascular response. Initially, there is vasoconstriction, then vasodilatation, then slowing of the circulation, and then the chemical mediators are released. In step one, there is margination. RBCs fall down from the laminar flow, they roll, they pavement, and ultimately they adhere to the endothelial walls. In diapedesis, WBCs, they extend pseudopods, and they get out from the blood vessels, and they pass out into the interstitium. In step 3, there is chemotaxis. Chemotaxis is unidirectional attraction of leukocytes from vascular channels towards inflammatory sites. So, place where inflammation is occurring, certain mediators are formed which are known as chemotactic agents. These agents act as magnets to specific blood cells, and each chemotactic agent is responsible for attracting its type of blood cell to the injury site. So, in this, initially, as it's acute inflammation, the chemotactic factors are going to be attracting the neutrophils, because those are the dominant cells of acute inflammation. Now, the important chemotactic factors for neutrophils are complement system, C5a, and bacterial mitochondrial products. And these WBCs, they are going to uh, get attracted to these chemical mediators, and through this attraction they are going to reach the injury site. In step 4, there is going to be phagocytosis, in which there is engulfment and internalization, and there is phagocytosis of these invading microorganisms, all the debris, the damaged cells, all those tissues which are lying there. And the phagocytic cells are responsible for this phagocytic process. The main cells are your neutrophils, your monocytes, and your macrophages. Now, in phagocytosis, first there is recognition and attachment. The body recognizes which cell has to be phagocytosed. Then there is a thing known as opsonization. Opsonins are basically plasma proteins which coat the substance which is to be phagocytosed, and when they coat this substance, the process of phagocytosis becomes enhanced. The major opsonins are Fc fragment of immunoglobulin, then complement systems 3b C3b or C3bi, B1, and then there is the carbohydrate binding proteins. Then engulfment pseudopods are extended, and they take in the debris which is to be phagocytosed. Then there is the killing. It can be of two types: oxygen independent and oxygen dependent. In oxygen independent, the lysosomal enzymes, they are used to degrade the and kill the uh, debris which is taken in. In oxygen dependent mechanism, again there are further two mechanisms. One is non myeloperoxidase dependent. In this, oxygen species are used, as these oxygen species, they have an unpaired electron in their outermost orbit. So what happens? This is an excellent mechanism through which the nuclear membrane and the cell membrane of the injurious of the etiological agent, uh, that can be destroyed by this mechanism. And when this is destroyed, the cells can easily then phagocytose and degrade that injurious agent. Now, the second is myeloperoxidase dependent. This is where hydrogen peroxide is it combines with a chloride ion, and it forms hypochlorous acid. Hypochlorous acid is one of the most effective bactericidal systems that you will find in a neutrophil, and it is very effective in killing your fungus, your virus, your bacteria, your protozoa. And it is known as it is recognized as the most effective killing response of our body towards these organisms. These chemical mediators, again, these are just to let you know, they are classified according to their functionality. Vasodilators, they are the prostaglandins and nitric oxide. Increased vascular permeability, in this there are the vasoactive amines. Then there is C3A and C5A, bradykinin and leukotriene C4, D4 and E4. Chemotactic agents are C5A, leukotriene B4, bacterial products and cytokines. Tissue damage is caused by neutrophil and phagocytic lysosomal enzymes, oxygen metabolites, and nitric oxide. Now, if you look at the morphology of acute inflammation, there is serious inflammation. In this watery, protein-free fluid is derived from the mesothelial cells and it pours into the body cavities. Fibrinous inflammation, this is due to more serious injuries. In this, the vascular permeability of the vessels, it is effective. Larger molecules like fibrinogen, they pass through the endothelial barrier, and again these can collect in your different body cavities. Now, as fibrogen, it gets deposited in these in these cavities. One thing that can happen is due to with fibrinolysis, these what do I call them? uh, these fibrins, they can completely get resolved, but in most of the cases what you will see is there is going to be scar formation, where the fibrin exudate is not completely removed and it is replaced by your fibroblasts and your blood vessels, which are forming your granulation tissue. Now, suppurative inflammation, this is purulent, in which there are large number of in which there is large amount of pus is formed, and in this, obviously, those organisms are involved which are known as purulent microorganisms, organisms which produce pus when infection is there. Now, there's a thing known as abscess. Abscess is focal collection of pus, and usually the infection is caused by pyogenic organisms. Again, pyogenic organisms are those organisms which can cause pus formation. Acute diffuse phlegmonous inflammation, in which there is a diffuse spread of exudate throughout the tissue spaces. There is not one single focus of I mean, you won't find any foci of infections or any foci of pus. In this, the whole infection is going to be distributed over a large area of the tissues. Classical example is cellulitis. Ulcer is a local defect or excavation on the surface of the organ or tissues. And what you are going to see in this ulcer, you will see cell necrosis and sloughing. Catral inflammation is where there is inflammation of the mucous membranes, and it is usually seen in the upper respiratory tract. Pseudomembranous inflammation, this in this there is extensive necrosis, and apart from the necrotic tissue, you are going to find neutrophils, RBCs, bacteria and tissue debris, and all of these things are going to be stuck with the healthy tissue. And if you try to separate this tissue, you will not be able to do so because it is deeply penetrating into the healthy tissue. Now, effects of acute inflammation, beneficial effects, dilution of toxins, protective antibodies, fibrin formation, plasma mediated systems, cell nutrition, promotion of immunity, and harmful. Obviously, acute inflammation causes tissue destruction, it causes swelling, it causes inappropriate responses like different hypersensitivity reactions. Of course, acute inflammation can resolve, or it can or you will see healing and repair, or you might see abscess formation, or you might see acute inflammation will go into a chronic stage. Chronic inflammation is which occurs for a prolonged duration of time, weeks or years, and usually chronic inflammation heals with healing and scarring. The dominant cells in this are the monocytic cells like your macrophages, your lymphocytes, and your plasma cells. Now, in this, macrophages are very, very important. Where chronic inflammation, you will see they play a very, very important role where chronic inflammation is there. The precursor the precursor cells of macrophages, they are present in the bone marrow, and they are released in the blood as monocytes. Within 24 hours, these monocytes, they convert into macrophages, and macrophages, they have a longer lifespan, and they have a more stronger phagocytic and lysosomal activity as compared to the monocytes. Then are the lymphocytes. They are of two types: T lymphocytes and B lymphocytes. B lymphocytes, they secrete antibodies. T lymphocytes, they promote inflammation. Eosinophils, you will see they are seen in parasitic inflammations, in hypersensitivity 1 reaction. And what these eosinophils do in these cases, they have a charged cationic protein, and this has a very toxic effect on the tissues. Then mast cells, they are distributed throughout our connective tissue. Now, granulomatous inflammation, this can be non-specific or it can be granulomatous. Non-specific is where there is a diffuse, distributed accumulation of macrophage and lymphocytes at the site of injury. In granulomatous inflammation, granuloma is formed. Granuloma is aggregate of epithelioid cells. Epithelioid cells are basically activated macrophages. When they all combine to form giant cells. There are two types of giant cells that can be formed by the aggregation of these epithelioid cells. Langerhans giant cells, in which the nuclei of all these aggregated cells are lined just like a horseshoe. Or foreign body giant cells, in which the nuclei of all these cells, they are dispersed within that giant cell. Causes of granuloma, there can be, again, the list is endless. These are just the headings, but they're the subgroups, they are endless: bacterial, fungal, helminthic, protozoal, chlamydia, inorganic, and idiopathic. Systemic effects of inflammation: fever, you will find endocrine and metabolic responses. C-reactive proteins, they increase. You see these in your acute your inflammations. Then glucocorticoids, they increase. Vasopressin, it decreases. Then you will see autoimmune responses. You will see behavior responses like rigor, chills, anorexia. Leukocytosis, where the WBC count is increased. Leukopenia, in some cases like typhoid fever or parasitic infections, you will see that WBC count decreases, and there might be weight loss. Now let's look at another one before we end this. We've seen healing and repair. Yes, hemodynamics. Here in hemodynamics, again, hyperemia and congestion. These are two very, very common terms which we use in both these conditions. There is increased blood volume within a tissue. In hyperemia, it is an active process. It is due to an increased inflow of blood towards the cell. Why? Due to arterial dilatation. And due to the arterial dilatation, when a lot of blood collects there, as this is oxygenated blood, that area, it appears red in color. Classical example is skeletal muscles, a physiological example of hyperemia. Exercising muscle, when you are exercising, you become red. Why? Because arterioles, they dilate, a lot of blood is coming there, and it's oxygenated blood, so it gives a red color. And pathologically, hyperemia, it's seen in acute inflammation. Congestion, it is a passive process. It is due to when there is some sort of an obstruction to the venous outflow, so there is stasis of the blood. Now this stasis is due to deoxygenated blood, so that area in congestion, it will have a more bluish color to it, because as the blood that is collected, it is deoxygenated. Systemically, classical example is seen in coronary failure. Locally, you will see in venous obstructions. Now, if you look at hyperemias, acute pulmonary congestion, hyperemia congestion, acute pulmonary congestion, and chronic pulmonary congestion. Acute cases, blood collects in the alveolar capillaries, and the hydrostatic pressure increases. Fluid, it moves out into the interstitium, causing pulmonary congestion. In chronic pulmonary congestion, as the disease it is of long standing, what happens? Chronic congestion, it leads towards healing and scarring. Scarring leads to fibrotic changes. Fibrotic changes then cause thickening of the septa, and what happens is, as it's a long-standing case, the alveolus spaces, they have got macrophages in them, and with time, as RBCs have leaked out of the vessels, these macrophages have engulfed them and ultimately degraded them. So these macrophages will be laden with hemosiderin. Similar is the case with liver, acute hepatic congestion, central vein, and the sinusoids, they will be distended. The hepatocytes around the central vein, they are going to be they are going to be they will be degenerating due to pressure effects and due to congestion, because there's going to be deoxygenated blood. Their blood supply is hampered, but the cells which are present at the periphery, usually they are spared due to the dual blood supply. In chronic passive hepatic congestion, central lobules, they are totally there is total cell loss. RBCs which have leaked out, they have been taken up by the macrophages and they have been degraded. Now these macrophages, they have hemosiderin in them. Now, edema, basically, edema, there is accumulation of interstitial fluid within the tissues. And if you look at them, the normal mechanism, there are two forces which are acting normally in our body. There's the hydrostatic pressure and then there's the osmotic pressure. Normally, at the arteriolar and hydrostatic pressure is more, so fluid leaks out of the blood vessels. At the venular end, the osmotic pressure is more, so the blood which has leaked out, it comes back into the blood vessels, and the residual blood which is left in the tissues, it is drained by the lymphatics. So in this way, the movement of the fluid, it is kept under control by the body. Now if the hydrostatic pressure increases, or the osmotic pressure decreases, or the lymphatics, there is some problem with the lymphatic outflow, all of these conditions are going to lead towards edema. Reduced osmotic pressure is seen in your nephrotic syndrome, cirrhosis, protein malnourishment. Lymphatic obstruction is seen in filariasis. This is a communicable disease in which your lymphatics, they are invaded by these organisms, and they block these things. Then lymphatics can be blocked if you are getting chemotherapy or some sort of a radiotherapy. Then sodium and water retention. Again, sodium retention, it increases the hydrostatic pressure and decreases the osmotic pressure. Classical example is acute renal failure. Again, in this case, due to increased hydrostatic pressure, fluid moves out of the vessels into the interstitium. Edemas can be subcutaneous, dependent, pitting, periorbital, pulmonary, or brain. Hemorrhage is extravasation of blood, that is getting out of the blood from the blood vessels, and its appearance can be a hematoma. Hematoma simply means there is accumulation of blood within the tissues. Hemorrhage can occur within body cavities, hemothorax, hemopericardium, or hemoperitoneum. Petechiae are hemorrhagic spots in the skin which are 1 to 2 mm in size. Purpura is hemorrhagic spots in the skin which are 3 to 5 mm in size. And ecchymosis are hemorrhagic subcutaneous hemorrhages, subcutaneous hematomas which are large, 1 to 2 centimeters or even larger. And the clinical significance is, it depends on the volume of the blood lost. If the blood loss is rapid, then yes, you will clinical pathological signs and symptoms can appear very quickly. But if it is a chronic blood loss, then the body has time to adapt. So sometimes in chronic blood loss, you won't find any significant major changes. Rate of bleeding, how fast you are losing blood, and the site of bleeding, what are the areas, which area is bleeding. It is going to depend on the sensitivity of that organ. So This was basically a quick roundup. The rest of the two chapters we have already done. This was just to revise with you the things which we had done in the university to assist you in exams. Thank you very much and good luck.